Kia ora tātou, everybody. Bruce Harrell's my name. I'm the director of the Goodfellow Unit. Tonight, it's a great pleasure to welcome Professor Katharine Wallis, who was originally in the General Practice Department at the University of Otago and then came to Auckland for a few years and is now at the University of Queensland in Australia, where she's head of the academy and head of the General Practice clinic there. She's been involved in this program called the Release Program, which is about helping patients get off their antidepressant medication. And it's quite interesting that this, I've been saying, is the biggest thing in primary care mental health in at least 25 years. And it's 25 years ago to this year that SSRIs became generic in New Zealand and became widespread. And we had to learn how to prescribe them, and now we have to learn how to unprescribe them, and Katharine will tell us about the science and the practicalities of doing that. So Katharine, lovely to have you on our show tonight, and welcome back to New Zealand.
Oh, thanks very much, Bruce. It's lovely to be here, and very, very grateful for the opportunity to share this work with everyone in New Zealand. So thanks everyone for turning up tonight. So, so this talk is about stopping antidepressants and how to do it safely. We'll talk a little bit about the who, the what, the where, the when, the where, and the why, and the how. Most importantly, the how is going to be what this talk is about. And the how is really using this release, 3A's brief intervention that we've developed and that we're testing in a trial in 28 practices in Southeast Queensland. And the intervention is designed to prompt and support people to safely stop their antidepressants by minimizing withdrawal symptoms. And so the 3A's intervention is ask, advise, assist, and we'll go through that as we go through this talk. So I'll start with a case study, and this is a real case just from last week. Because we're doing the release study, I get patients emailing me. Not my patients in practice, but so this email just came in last week. Dear Professor Wallis, thank you for your work on hyperbolic tapering. I want to wean off my SSRI. My GP wants me to reduce it in 25% increments over a few months. However, I have been on an SSRI for almost 30 years and concerned about the risks of reducing so quickly. I want to do hyperbolic tapering. Can you suggest any Australian guidelines or official documents I could provide to my GP to help persuade him to let me try hyperbolic tapering? I'm on Zoloft, which is sertraline, 100 milligrams. I've been on it for almost 10 years. Prior to that, I was on Paxil, which is paroxetine. I was advised to switch ahead of pregnancy. I was on Paxil for almost 20 years. So I sent her through, I responded, and then a few days later, she got back to me and she said, wow, this is amazing, extremely helpful. My GP appointment is in about 2 weeks, so I'll let you know how I get on after that. Once again, thank you so much. So a little bit of a spoiler alert. What did I send her that she sort of thought was amazing? And it's this here, which is the release hyperbolic tapering protocol, which comes with all the instructions on how to do hyperbolic tapering, and a schedule with the step-by-step dose reductions, which we'll go through a little bit more quickly. So that's a sort of a spoiler alert, what this talk is all about. And we're using these, we developed these for the release trial, which is redressing long-term antidepressant use in general practice. And we received funding for this trial more than 2 years ago now. And it's a randomized controlled trial, effectiveness implementation hybrid type 1 design in 28 practices in Southeast Queensland with 590 adults on long-term antidepressants. And by long-term, we mean longer than 12 months. And we're testing the release 3A's intervention, which is this brief intervention, ask, advise, assist. And we've developed resources that we're testing as part of this ask, advise, assist. And the resources are brochures and a decision aid, and these hyperbolic tapering protocols that provide practical step-by-step instructions for how to come off antidepressants. And these resources were informed by a Think Aloud study that we ran with adults with lived experience of long-term antidepressant use. And for our release trial, we've got a theme song, which is Engelbert Humperdinck's Please Release Me, Let Me Go, Release Me, and Let Me Love Again. So that's particularly pertinent when you're thinking about antidepressants. So just quickly, these are our resources. So this is the Stopping Antidepressants brochure. It's a trifold brochure, talks about antidepressant use and what the options are. And one of the participants in the Think Aloud study said about this resource, I wish I'd known that, especially the 6 to 12 months being a therapeutic guideline. Another one said, I just thought once you're on them forever. And another participant said, I'm blown away by the 1 in 7. So in Australia, 1 in 7 people are on antidepressants, currently taking antidepressants. So we've also developed a trifold brochure for how family and friends can help supporting someone go through this journey of discontinuing long-term antidepressants. And we've developed a decision aid, which helps people to weigh up their options, what stopping antidepressants is all about, what continuing could mean, and then they can go through helps them decide what's right for them and where they're up to on each of the reasons for stopping or reasons for continuing. So to help people make a decision about whether or not they want to take action or whether or not it's the right time now. And participants in our Think Aloud study said it's nice to see it broken down into a pretty straightforward pros and cons type list. And I think that helps a lot of people, really puts it into perspective what their options are. And another one said, well, if you show this to your GP, for example, they can then gain a lot of information from that as well. And you don't have to try and put all your thoughts into words as well. So I think it's quite helpful. And then we've got the hyperbolic tapering protocols. So this is the one close up. I hope that's not too close up. For the sertraline, it's an even slower version. So we have the slower version, the faster version, and the even slower version, which is the providing 2.5% decrease in the sertraline transporter occupancy. So you can see that the even slower tapering protocol, which is the one that I provided to the patient in the case study, has got 38 steps, starting at 100 milligrams, down to 75 milligrams, then 60 milligrams, then 50 milligrams, then 44. And the hyperbolic part of it is taking smaller step downs in drug dose as you go down in smaller doses. And the reason for that is to give a steady decrease in SERT occupancy. So hyperbolic tapering means that at lower drug doses, you need to go more slowly, because by decreasing the drug dose in hyperbolic regimes, it gives a steady decrease in SERT occupancy. So if you go from 100 milligrams to 50 milligrams in that table, down to step 2, that reduces the occupancy from 85% to 80%. And then if you go from 50 milligrams down to 25 milligrams, you go down to 70% occupancy. So you're getting that steady up to 10% decrease in SERT occupancy with that hyperbolic tapering. So step 5, you've gone from 100 milligrams down to 10 milligrams, and you're only about halfway there. So 100 milligrams down to 10 milligrams of sertraline is around about as far to go as from 10 milligrams down to 0 milligrams. And that's often quite a difficult message for people to understand. And the importance of that is by getting this steady decrease in SERT occupancy, you can minimize withdrawal symptoms and give the brain time to adjust to being without the antidepressants. And we've got 3 speeds for the hyperbolic tapering. So the faster one, which is this one's an example of that, gives a 10% decrease in SERT occupancy. The slower version gives about 5% decrease when they have about twice as many steps as this one. And then the even slower tapering protocol, which gives 2.5% decrease in SERT occupancy at every step. And this is just a figure to help try and explain the hyperbolic tapering. And you can see on the vertical axis, the drug dose goes from 60 to 20 to 6 to 3 to 1. Those would be your step downs, the hyperbolic step down in drug dose, which is giving the steady decrease in brain receptor occupancy. And these hyperbolic tapering schedules were informed by Mark Horowitz, who's one of our co-investigators on our release trial. And Mark, just this year, obviously, has published his Maudley De-prescribing guidelines. So we're using not exactly the protocols in here, but certainly very similar that Mark helped us develop a couple of years ago. And the reason we're not using them exactly the same is just to try and get the dosing of the drug mini doses availability is problematic. So if we now go back to the who, what, when, where, why, and how, and our ask, advise, assist intervention, the who and the what of it's pretty straightforward. Who is pretty much anyone who's been taking antidepressants long-term or longer than 12 months. Obviously, some people will stop antidepressants before 12 months, and if they wanted to stop sooner, they can use hyperbolic tapering to stop if they want to. But people who stop before 12 months tend not to have such a lot of difficulty stopping as people who've been taking antidepressants long term. So the longer you've been taking antidepressants, the more likely you are to suffer withdrawal symptoms, and the more likely you are to need to use the hyperbolic tapering regime to come off these drugs. And what we're talking about, obviously, are antidepressants. In the release trial, we're focusing mainly on SSRIs, SNRIs, and other antidepressants, such as mirtazapine. The when would you consider stopping an antidepressant? When the patient wants to, when the clinical guidelines recommend, and most clinical guidelines recommend 6 to 12 months for a single episode of moderate to severe depression. Long-term use is generally not recommended for most people. You might consider stopping if the antidepressant doesn't work or is not working, or you might consider stopping if the antidepressant is causing adverse effects. So you're always, as a GP, and as a GP myself, I know, always balancing up the potential benefits and the potential harms. And when you might do this is whenever somebody presents for a repeat prescription of their antidepressant. So if somebody's been on antidepressants for longer than a year, they've been getting a repeat prescription, every few months for that period of time. And each time they get a repeat prescription is an opportunity to ask. And what do you ask? You ask the patient, how long have you been taking antidepressants? So how long in total? So they might have started with you, or they might have started with some other GP. But it's important to sort of, have that discussion. How long is it now? How many years? And have you ever tried to stop? Because if somebody's tried to stop previously and experienced withdrawal symptoms, that they're more likely to experience withdrawal symptoms again. So that will inform your approach to helping them stop. Where is in general practice? And this is because we GPs are prescribing most antidepressants. This data is from Australia. So this is the number of mental health related prescriptions. And obviously antidepressants is by far and away the most commonly used mental health related medication. And all the antidepressants prescribed in Australia, 92% of them are prescribed in general practice by GPs. Psychiatrists are the light blue bar, not very many antidepressants prescribed by them. And then there's a few other non-psychiatrist specialists prescribing. I'm not sure about New Zealand, but in Australia, we're finding that the gynecologists are using SSRIs and SNRIs for women going through menopause. So I don't know whether it's the gynecologists, but that certainly seems to be a bit of a trend at the moment. So it's really a general practice problem. And so why would you want to stop antidepressants? There is increasing antidepressant use, and these data show that in Australia over the 20 years, 2000 to 2019, the use of antidepressants trebled. And we know that a lot of this increasing use is increasing long-term use. Around about half of people taking antidepressants have been taking them for longer than 12 months. And this tends to suggest that people start these drugs and then they find they can't stop. So while the clinical guidelines might say 6 to 12 months as a therapeutic course. Many people are taking them for longer than that because they just find they don't feel good when they stop. Increasing use in Australia compared to the Netherlands. This is over the last approximately 10 years. The use has continued to increase in Australia, whereas countries like the Netherlands have put quite a bit of effort into this particular prescribing topic and have managed to contain antidepressant prescribing rates, keep it around about the same over the last 10 years compared to, at least in Australia, it's gone up a lot, to the extent that now in Australia, sertraline and escitalopram are in the top 10 of prescribed drugs, up there with the cardiovascular drugs, the statins and the blood pressure drugs. More people are taking sertraline than are taking metformin. And the use has really skyrocketed of those two drugs in particular, but also the venlafaxine and duloxetine. And another thing that might suggest that there's a bit of an issue and that perhaps increasing antidepressant use is a topic worth looking into is that there's unwarranted variation in antidepressant prescribing. Older people, people over 65 are twice as likely to be on antidepressants as people under 65. Women are around about 1.5 times as likely to be on antidepressants as men. And antidepressant use is also higher in poorer, lower socioeconomic regional areas. And I mean, this might be an issue because we know that antidepressants can't treat grief, loneliness, unemployment. And so this led to the Productivity Commission Mental Health Inquiry report in 2020 in Australia, where the Commissioner said that an area for priority reform was looking at adverse outcomes from mental health medications, and that antidepressant prescribing was, because of its frequency of use, the topic to concentrate on, which is partly why we concentrated on this topic for the release work. So why stop antidepressants? On an individual level, you could have a discussion with your patient that long-term use is not harmless. There are adverse effects associated with long-term antidepressant use. Long-term use is not recommended. There's no good evidence for the benefits of long-term use. And depression is not a long-term condition caused by a chemical imbalance in the brain. So there's the sort of population level prescribing data that might raise concerns, but at an individual level, there are some good reasons that people shouldn't be continuing antidepressants. The antidepressant adverse effects include lethargy, fatigue, lack of motivation, weight gain, and some evidence that it increases the risk of diabetes, sexual dysfunction, which is decreased libido and difficulty achieving orgasm in both men and women, emotional numbing, that people talk about feeling numbed or flattened, which is a reduction in positive feelings as well as negative feelings. So obviously, if you're very distressed, it might be good to feel this is being numbed, but in the long run, being numbed does mean you miss out on the good things in life as well. And in older age, antidepressants contribute to the burdens of polypharmacy and are associated with increased risk of falls and fracture. And there's also the sort of relational issues that people talk about in the qualitative research on this topic, caring less about others, and a reduced ability to feel love and affection. So hence our theme song. And so so this information is in our Stopping Antidepressants brochure, and one of the participants in the study said that I had that impression that long-term use was not recommended. I could have done something. My life would have been quite different. I have suffered weight gain, low sex drive, inability to achieve orgasm, emotional numbing, fatigue, lack of motivation, and sleep disturbance for the last 18 years. I only needed to go through that for 1 year. I wish I had that information. I would not have been on them for so long. So when it comes to the advised part of the intervention, we talk about advising patients about the clinical guidelines and the recommendation that therapies for 6 to 12 months for most people. We talk about advising also that depression is not a long-term condition caused by a chemical deficiency in the brain. The serotonin deficiency theory that people have been talking about a lot, it's not grounded in science, but has been quite a successful theory that people sort of latched on to try and explain, I think, the difficulties that they were suffering or experiencing in their lives, and it kind of made sense to think there's something wrong with my brain and I can take a pill that fixes that and then everything will be better. But there's no evidence that that is the case. So why don't people stop antidepressants? Why haven't people been stopping them? When you talk to people, the patients say that they would expect their doctor to suggest stopping if it was warranted. So they're waiting for their doctor to suggest stopping when they ask for a repeat prescription. They also say they've experienced unpleasant withdrawal symptoms, and they also fear relapse. That's quite a big concern for patients. They don't want to go back to where they were before. Doctors say they're reluctant to rock the boat and destabilize a stable situation. They're suffering time constraints, or we're suffering time constraints. We're busy. It's easy to check in with our patients, see if everything's okay. Or you want to stay on it, that's fine. Patients might say they fear relapse. We also lack tapering guidance in general practice, or we have done. And there's often poor access to non-pharmaceutical alternatives. It's easier to provide a prescription, and patients often want a prescription. So that's the easy option often. So the fear of relapse, this is just one of our participants in the Think Aloud study, is definitely what resonates with me. That's the sole reason I'm still taking them. So we need to advise patients about withdrawal symptoms and let them know that they're common and that they can be severe. So antidepressant withdrawal symptoms include anxiety, worsened mood, trouble sleeping, crying spells, mood swings, anger or irritability, suicidal thoughts, and all of those symptoms can be readily misconstrued as relapse. But withdrawal symptoms also include distinguishing symptoms like dizziness, confusion, headache, nausea, brain zaps, which aren't part of anxiety or depression. So we need to advise our patients that withdrawal symptoms are often mistaken for relapse. And this is often what patients fear. They fear this terrible feeling, which they interpret as relapse when they stop taking their drugs. Anxiety, worsened mood, trouble sleeping, crying spells, mood swings, anger and irritability, suicidal thoughts. And you can see in the PHQ-9, which is what we use sometimes to measure depression, the symptoms or on the part of the PHQ-9 is feeling tired or having little energy. The DES on the right column there is what we use to measure withdrawal symptoms, and that's got fatigue in it. The PHQ-9's got being fidgety or restless. The DES has got agitation. The PHQ-9's got trouble falling or staying asleep. The DES has got insomnia. And when it comes to measuring anxiety, we often use the GAD-7 score, and that's got feeling nervous, anxious, or on edge as part of it. The DES has got anxiety/nervousness. The GAD-7's got becoming easily annoyed or irritated. The DES has got irritability. So you can see how it's easy for patients and doctors to, and researchers, misconstrue some of the symptoms of withdrawal as relapse of depression or anxiety. So you want to advise your patients how to recognise withdrawal symptoms and how to distinguish that from relapse. So partly it can be helpful, the timing, the onset of symptoms. Withdrawal symptoms come on within hours or days or sometimes weeks after stopping or decreasing a dose of antidepressant, and they can last for days, weeks or months as well. The second way to try and distinguish is that withdrawal symptoms are readily relieved on restarting antidepressants. So usually within a day or two, people will feel better. And you know that if somebody's suffering from anxiety or depression, feeling better when you start drugs takes a lot longer. So if it's readily relieved on restarting antidepressants, then it was withdrawal symptoms. But there are also these distinguishing symptoms. So the distinguishing symptoms include dizziness, lightheadedness, nausea, headache, what people describe as brain zaps, also increased sensitivity to light and sound, feeling of depersonalization, sweating, muscle aches and cramps, and of course, being quickly relieved on restarting antidepressants. And patients often aren't aware of this. One of our participants in the Think Aloud study said, it hadn't really occurred to me to think about the difference between withdrawal symptoms and relapse. So that's really useful information. So often our patients aren't aware. And withdrawal symptoms are more likely with longer duration of therapy. So that's why it's important to ask people how long they've been taking these drugs, and more likely if they've experienced withdrawal symptoms previously. And some antidepressants are more likely to precipitate withdrawal symptoms as well. So the worst offenders tend to be desvenlafaxine, venlafaxine, paroxetine, duloxetine, and mirtazapine. So coming back to why stop antidepressants? And it's largely for the health and quality of life benefits. It's not for any other reason. It's just that it's better for people's health and quality of life if they're not on these drugs when they don't need to be on them anymore. So they often feel more energy and motivation. They've got improved weight control, decreased polypharmacy and decreased risk of falls, which is obviously important for the older people. Improved sexual functioning, although unfortunately the sexual adverse effects can be long-lasting. Increased ability to feel joy, love, excitement, and to care for others. And of feeling free of being dependent on medication. People talk about, it's nice not to sort of have to take a tablet to get through every day. That's quite a liberating kind of feeling. And obviously there are the financial benefits, not having to see your GP all the time for prescriptions. So this leads us to the big question on how to stop antidepressants safely. And this is where the assist comes in. So you assist your patients by providing them with a hyperbolic tapering protocol. And these tapering protocols, as I mentioned before, have been designed to minimize withdrawal symptoms and help people to safely stop antidepressants. So this is the tapering protocol schedule, and this is the 2.5% decrease, so very slow. And people would take a step down in drug dose every 2 to 4 weeks, sometimes weekly, but this one's got 38 steps. So at the very, it's going to take people, at least a year, if not more, to get down slowly following this tapering protocol. And a common mistake that people make is that they think, oh, I've gone from 100 milligrams down to 11 milligrams. Surely I can just stop there. But you can see on this tapering protocol, you're not even halfway there. Once you've gone from 100 milligrams down to 11 milligrams, there's a lot more steps and a lot more fiddly little bits of medication to find and take. So these are the tapering protocols that we've developed. So there's the slower, the previous one was the even slower version using a 2.5% decrease. And these ones are the slower version and the faster version. And also we've developed versions using capsules or liquid formulations. And I know Bruce was telling me in New Zealand there's only the liquid for fluoxetine. So we provide instructions to help people taper, and by making their own liquids, crushing a tablet, mixing it with water, and drawing up the number of mils. So there is a little bit of fiddling about with that. And so not everyone wants to do the liquid formulation. So you can follow the capsules, use capsules, compounded capsules available via the compounding chemist. So the two decisions people need to make do they want to use capsules or do they want to use liquids? And then do they want to follow the slower taper or the faster taper? And as I mentioned before, some drugs and some people who've been on these drugs for longer and some people just being the way they are more sensitive to withdrawal symptoms, and they might want to follow the slower taper or the even slower taper. So you essentially start at the current daily dose and take your step downs, and it's very important to draw people's attention to the bottom half of the table, because it's a common mistake that people make, thinking I've got down to 10 milligrams, I'm fine, I can just stop. But it's very important to keep going all the way, going slowly. We've developed these protocols as flexible protocols. So if the cat dies or something like that, and people just want to stay on that same dose for longer than 2 to 4 weeks, or they stay there, and then when they feel ready, they go down to the next level, next dose. If people suffer withdrawal symptoms or very bad withdrawal symptoms, we tell them to go back up to the previous dose, settle until things settle, and then when they feel ready, try again, taking a smaller step down in drug dose when they're ready. So it's a flexible regime. And so that's just the close up there of using the compounding capsules. So you'll see to follow this schedule, patients need to get 5 milligram capsules from the compounding chemist, 1 milligram capsules and 0.5 milligram capsules to be able to follow this schedule all the way to the end. And what patients have said about these tapering protocols is partly it takes a little bit of the fear away. It's really good to have an individual tapering protocol. You feel more like it's set for you rather than generic. I think it takes a little bit of the fear away to know that I can do it more gradually if I wanted to. And another participant said, I wish that every GP and psychiatrist who's prescribing this drug had this amount of information and awareness. It would make life so much better for people who've been prescribed this drug and want to come off. So as a GP, you're going to provide the tapering protocol, and you're also going to assist by providing instructions for how they can access the mini doses. What the ANZ College of Psychiatrists said was that reducing the antidepressant in such a way, the hyperbolic way, is impractical, as current preparations of antidepressants do not allow for the dose to be reduced by small decrements. And so that's why we GPs need to assist our patients by providing with prescriptions that they can get made up at the compounding chemist, or instructions for how they can make the liquids by crushing the tablet and mixing it with water. Not all antidepressants are available in tablets that can be crushed, though. So there's compounding capsules option only for some of the antidepressant drugs. I think there's 3. So this is the liquids. This is the liquid version of the slower and the faster taper. And we've got the instructions there for how to make the sertraline liquid when it comes to when they get to that liquid level. So they crush a quarter of a 50 milligram tablet between 2 teaspoons over a small plate. Place the crushed tablet into 12.5 mils of water in a bottle or jar. Shake vigorously. The tablets disperse in 1 to 5 minutes. Measure the prescribed daily liquid using a syringe and consume. The solution may have a bitter taste and slight numbing effect on the tongue, so take care with hot drinks and food. Make fresh solution daily and discard unused into the rubbish. So we tell people to discard it into the rubbish rather than down the drain, because evidently there's so much antidepressant circulating that it's actually now affecting the fish in the water. So that's a bit depressing in itself. So those are just a close-up of how to make the liquids, the instructions. And people, they'll need a pill cutter, they'll need a 10 ml and a 1 ml syringe and a bottle. And we've got a QR code that takes people to a little video to show them how to do it. And it's actually been surprising how well people have managed making the liquids, because we were sort of a little bit hesitant that people would be able to manage it, but people become their own best taperers or dose, managing this themselves. So just another case study to demonstrate how this Ask, Advise, Assist intervention might work in your practice. If you might have, for example, a 70-year-old woman, she's overweight with diabetes, high blood pressure and arthritis. She's a widow, has been for 15 years and living on her own. She's not doing much in the way of exercise. She's got sore knees and feeling a bit tired all the time. And she's come to see you for repeat of her medications. She's on a statin, an ACE, metformin and paracetamol and sertraline, 100 milligrams. So she's just asking for a repeat. And you think, right, I'm going to ask her about her sertraline. So you would, first of all, you would ask her, how long have you been taking sertraline? And she'd say 15 years. And then you'd say, have you ever tried to stop? And she might talk about her experience stopping. And then you would advise her that long-term antidepressant use, 15 years, is not harmless, and particularly as she's now 70 and going into her older age, being on this drug is going to increase her risk of falls. Long-term use is not recommended for most people, and that depression is not a long-term condition caused by a chemical imbalance in the brain. And you can see that she's been widowed for 15 years and she's been on sertraline for 15 years. And often that's what happens to people. They start the antidepressant during a time in their lives when they're suffering a lot of distress, grief, stress, relationship difficulties, and then they just find they can't get off it and continue taking it. So you'd also advise her about withdrawal symptoms, that they're common, that they're severe, but that they can be minimized through hyperbolic tapering of the antidepressant drug dose to enable her to come off this drug. So that you would then assist her by providing a tapering protocol and also giving her advice about how she can access the drug mini doses. So that is just a summary of the release intervention, which we've developed to prompt and support safe cessation of long-term antidepressants. Ask, advise, assist. And I'm very happy to share with any GPs on the line who would like to have these resources. You can send me an email. So I have rushed through that, Bruce, but just acknowledgements for our participants in the release trial and the GPs and the practices who are participating in the trial, the steering committee and the consumer advisory group as well. Also my co-investigators and funders and partners.
So we've got a bunch of questions here. Any guidance for antipsychotics, or do we have to have a look at the manual?
That's not my area of expertise, but it does seem to be the hyperbolic tapering regime is also used for antipsychotics and other drugs. So it's not particularly unique to antidepressants.
Okay. So a question here from Carmen. How quickly will someone feel relieved after restarting it if it is withdrawal symptoms?
Usually fairly quickly, within a day or two. When I say fairly quickly, usually within a day or two. I mean, it might be up to a week, but it's usually fairly quick. If somebody's stopped suddenly, or if they've taken a step down and then are starting to feel a bit wobbly.
The tapering regime for venlafaxine, is that how would one get hold of that?
Yes, so venlafaxine is one of the ones that we can't use the liquid formulation, so it has to be the mini doses available via a compounding chemist. You have to get the capsules made up. Okay,
so Linda says yes, the dispersible is available. Mel saying fluoxetine liquid. I don't think there's a liquid version here, but there is a dispersible form.
Yep.
Do you suggest, so here would the easiest thing be to switch people over to fluoxetine? What are the issues there?
that's not really recommended. That's one of the things we used to try, because fluoxetine is one of the ones that's slightly easier to come off. But if somebody's been on, for example, paroxetine or venlafaxine or something like that for a number of years, and you suddenly stop it and think, oh, go on to fluoxetine and you'll be fine, they won't be fine. Definitely won't be fine. So no, doesn't tend to work terribly well, the swapping and going down that way.
Are there some worse than others for withdrawal? I'm just thinking, I've always thought that
Yes.
paroxetine and venlafaxine were tricky ones, and maybe to avoid them in the first place, because from the Furukawa review, there was no difference in effectiveness in different ones. Although venlafaxine has this image of being treatment-resistant depression, I think that's more marketing than science.
So yes, there are some of these antidepressants that are more difficult than others as far as withdrawal symptoms go. So venlafaxine, desvenlafaxine, paroxetine, duloxetine, mirtazapine, the half a dozen of them that are worse or more difficult to get off than others. And so yes, I think that's probably a fairly good strategy, Bruce, if you can try something else instead. Don't use those ones.
Starting, what's your favorite ones?
I very, very seldom would start these drugs, I have to say.
I think sertraline is the nod here because of you can use it in pregnancy, doesn't have cardiovascular things, and it's reasonably long acting in terms of tapering. Is that your view, or?
I don't know that there's any evidence that sertraline's any safer than any other in pregnancy. So I would be very hesitant about that. I mean, I just can't see how it couldn't, have an effect. I would be very nervous about that. I mean, probably the use of these drugs, or in Australia, sertraline and escitalopram, huge, is not related to the evidence of how beneficial or otherwise these drugs are. The prescribing rates tends to be more influenced by other factors,
Such as,
such as social media, any other factor that affects GP prescribing rates, basically. Well, virtually everything.
Different ethnic differences. It's very unusual in New Zealand for Maori patients to come in and ask for antidepressants. It's not the demographic that does it. I'd say it's often younger Pākehā females who would come in asking for antidepressants, and younger Pākehā males. Any comments on that?
We certainly know that use has gone up across the board, whatever age group that you're in. And the problem, I mean, our research is focusing really on the long-term use and how to support people to stop these drugs safely, given, the severe withdrawal symptoms that some people can have and how dangerous their symptoms can be. So that's where our research is focused. But because a lot of people are starting them, and whatever age they're starting them at, they don't tend to stop them. It gets to be cumulative, and that's why, or partly explains the very high use in older people, and even high use in residential care. I think in Australia it's about 60% of people in residential care are on antidepressants.
Wow.
Which is
Question: how quickly do you do the steps? Step 1, step 2. That's a moving feast, I gather.
Yeah, so I think that's a really good question. I mean, we say 1 to 2 weeks or 2 to 4 weeks, but that it's flexible, because some people certainly can come down more quickly. They could do weekly step downs, and particularly if they've not been on antidepressants for very long, and they're on one of the antidepressants that are not, very high risk for withdrawal symptoms. So that could work. But everybody is different. So that's why we quite like the flexible tapering approach, and we try and say to patients, or to say to GPs, to say to patients, it's flexible. Aim for 1 to 2 weeks or 2 to 4 weekly step downs, but don't be disappointed if you stay on a particular level for longer, or life gets in the way, there's other things happening and you don't want to, rock the boat, take that step down, which is a little bit problematic for the tapering schedule, because people quite like to be able to sort of, have a date, have a plan, follow something precisely. Or in some countries, you can get those tapering strips where you'll be given this dose for 2 weeks, and then you'll be given this dose for 2 weeks, and then you'll be given this dose for 2 weeks, and you don't need to think about it. You just pop your dose and keep going down. So that, for some people that works well. But for others, the flexible approach works well. So a general sort of, rule of thumb, aim for 2 weekly step downs in drug dose, but it's flexible depending on how you're feeling.
So question there, is there any difference in the reason why somebody went on to them for anxiety, depression, PTSD, menopausal symptoms? Do you find any difference, or is it still it's going to be the same issues irrespective of the initial diagnosis?
The way I see it is that the withdrawal symptoms, it's a physiological withdrawal syndrome. It's something going on related to the drug. And some people are more sensitive, and more likely to experience them than others. But it's different to the psychological distress that people were suffering at the time that they started the drug. And so previous research has looked at psychological supports to help people come off antidepressants, thinking, they haven't quite recovered from their psychological distress. If we replace drugs with CBT or something else, some other therapy, they'll be fine. Our research has taken a different approach, and we're saying these are well people. They've been on these drugs for 15, 20, 10, whatever years now. These are well people, but they experience physiological withdrawal symptoms when they attempt to stop taking these drugs. And that's why the approach that we're using is we're not replacing it with therapy. We're saying this tapering regime can help people and help their brains adjust to living without these drugs. And if there is a degree of psychological distress in their lives, or they want to develop skills to help cope with anxiety or distress or relationship challenges or whatever it is, that will be needed, or that could be helpful anyway. But this is very much about the changes that the drugs have induced, and trying to help the brain readjust to living without these antidepressants in a very slow and a hyperbolically slow way.
Question here, what about people who are on SSRIs but continue to feel down or anxious? It's interesting, the reason I did the Cochrane review was that our practice was full of people on SSRIs who were still feeling down and anxious. And I seriously wondered whether they worked at all, and was surprised when I did the review. But as I was saying to you before, the published antidepressant data is all on severe or very severe patients, which is the end where antidepressants are more effective than at lower ends. Presumably somebody's not getting any benefit from the drug, so they might as well be off it.
Presumably somebody's not getting any better for them, and in my kind of eyes, that would be a good reason to not take it. If it's not helping, if it's not fixing the problem, and why would you take it?
Isn't that the trap? You maybe don't need the drug, but then you get put on it, and then you can't stop it. I mean, that's a real.
Well, it's not about need, but certainly once you're on it, you can. Many people have trouble coming off it, and that's what this is about. So, regardless of whether you should have started it or not, or regardless of whether it's helped or not, if you want to come off it, given the severity of withdrawal symptoms that some people can experience, this is a way to come off safely.
So how successful is tapering compared with other weaning strategies?
I think that's a very good question. I don't think we know the answer to that just yet. We don't know the sort of perfect tapering regime. We don't know. There's no research saying 2 weeks is better than 1 week is better than 4 weeks or whatever it is. And we also don't know the size of the step that is the optimal size of the step down. So whether it's the 2.5% decrease in occupancy, which is, our even slower version, the 5% decrease, or the 10% decrease, which is the faster version. So the research hasn't been done on that yet, and we don't know the answer to that. And I suspect it's going to be different for different people, and it's going to be different for different drugs. And that's why I think the flexible approach and letting each person be their own best kind of guide, if you like, is a good place to start.
I remember from that webinar you did for Australia about 2 months ago, they were talking about where the interest in this came was that the user groups were finding slow tapering was working, and then the docs started to realize that that actually there is something to this, and that's how it got started. Is that correct? Is that the sort of backstory?
Oh, no, well, there has also been work looking at brain imaging techniques, and that demonstrates this hyperbolic relationship between transporter occupancy and drug dose. So that's where the hyperbolic sort of relationship developed. But certainly there's a lot of online support groups and very active sort of voices and things. And, people with lived experience have contributed a lot to research and work in this space.
Mel would like to know a little bit more about cert occupancy, How does this relate to efficacy or withdrawal?
Good question. I don't know how it relates to efficacy. We're not focusing on, whether or not these drugs work and how well, if so, how well they work. We're sort of at the other end of the spectrum, trying to get people to come off them safely and slowly when they're ready to come off them. But so how does it relate to how the withdrawal syndrome or the withdrawal symptoms? So again, that's an evolving field, but the greater the step down in drug dose, gives the greater reduction in the serotonin transporter occupancy. And the greater the change in occupancy, then the greater the severity of withdrawal symptoms, is the theory, is the thought. So that's why the 2.5% decrease, or the little steps in drug dose, are hyperbolic nevertheless, but very small steps, gives only a very small decrease in occupancy, and then is less likely to precipitate withdrawal symptoms. Oh, no, I was just going to say that it's a steadiness, whether it's a 2.5% decrease each time all the way down, or 10% decrease, each time all the way down. It's trying to get a steady decrease in occupancy through the hyperbolic decrease in drug dose to give the brain a consistent sort of adjustment that needs to be made as you are trying to wean off the drugs.
When you're coming down these very low level tapering, do people get a re-emergence of symptoms very often, or is it a fairly steady pace without too many problems? What proportion of people would you have to go back up a level?
Look, it depends on the drug and it depends on the person, but the common problem that people make is that they have sort of got a bit of wind under their sails by the time they get to the lower levels, and they think, oh, I've got so far through, I'll be fine now, and they think I'll stop. So that's a very important part of the instructions for the GP to give people, is that those lower doses are often the hardest ones, and it's very important not to skip them. So even though it sounds silly, I'm going from 4 to 3 to 2, when I was on 150, that is still very important, and it's about that percentage occupancy decrease that you're wanting to maintain the same.
Andrea is asking, is it okay in the first steps just to cut the tablets into smaller tablets
Yep, absolutely. So that's what we do.
Yep.
If you've got your pill cutter and you can take, if the dose, if it lines up with the schedule, you can take a half dose or a quarter. Usually beyond a quarter, it all gets a bit messy. So we tend to go down to a quarter and then recommend mixing it with liquids.
Question.
Into a liquid.
Somebody who said, having been on paroxetine for 24 years and having tried to come off it 3 times with no success, is this one that would do well under a tapering plan? And is that one that could be compounded?
Yes and yes. But so paroxetine we know is one of the high risk drugs, and if this person's been on it for a couple of decades, you would want to go slowly. So you would want to use the even slower tapering protocol, aiming for around about 2.5% decrease in occupancy at each step.
Anonymous question, is taking SSR on alternate days the same as reducing the dose by 50%?
Yeah, so that's a really important point, and I should have brought that up earlier. That's commonly been used before, drop down to 1 a day and then take 1 alternate days and then stop. And that's very likely to result in withdrawal symptoms. So it's highly recommended that we avoid that advice and don't do that anymore. So try not to do that, because it just will result, highly likely to result in withdrawal symptoms. And no, it's not the equivalent. 1 every second day is not equivalent. Is not the same as half every day, or at least not for the brain.
So, question here: how do you know who really needs them long term? Because I guess I thought the evidence said there's a small percentage of people who benefit long term. I think you've demonstrated in Christchurch.
Yeah, I think it's really hard to know the answer to that question, because a lot of the evidence, and I showed you the PHQ-9 and the GAD-7 and the DES, a lot of the evidence, people haven't distinguished between withdrawal symptoms and relapse when they're trying to say, okay, go on, we better go on them and better stay on them to prevent relapse. There's high suggestion that a lot of people are on these drugs not to prevent relapse, not to prevent relapse, but to prevent withdrawal symptoms, or and not to treat depression and anxiety and irritability, but to treat withdrawal symptoms and prevent withdrawal symptoms.
I was going to say, one of the points I took from that Australian program you were on, they said that the withdrawal effects turn up quickly. The actual symptoms would take way, way longer to actually appear. Is that?
Yep, that's one of the distinguishing features, to help people distinguish between relapse and withdrawal. But sometimes withdrawal symptoms can come on weeks later as well. So people might feel fine for the first couple of weeks, and then they start to experience withdrawal symptoms. So withdrawal symptoms can come on like within days if people go away for the weekend and forget their antidepressant medication. They can feel it. But sometimes it can be a couple of weeks delayed as well.
Andrea's got a question here. Do we know what percentage of patients that take these medications will have severe withdrawal symptoms? I mean, I don't know if you know a figure on that, or whether you could give an estimate.
No, I don't know exactly, and I think that research hasn't been done, to measure that accurately. But I would say around about half of the people currently taking antidepressants have been taking them for longer than 12 months. And it's probably the people who are taking them long term, or have been taking them for longer than 12 months, that are experiencing withdrawal symptoms, or, that seems likely. So, at least half there was the Lancet psychiatry thing published recently. I think it was Lancet. Anyway, talking about 1 in 6 people, experiencing withdrawal symptoms. But that systematic review and meta-analysis, most of the studies that were included, the people in those studies had only been using antidepressants short term. They were efficacy trials, and so maybe we can say something like 1 in 6 people who take antidepressants short term experience withdrawal symptoms. And I would suspect that most people taking them long term will experience withdrawal symptoms, and I would recommend not stopping them antidepressants suddenly in those people.
Certainly in the primary care studies, very few of them go longer than about 10, 12 weeks. Basically, 12 weeks is a long trial. Question about the tricyclic antidepressants. Is there a tapering schedule for these?
Yes, there is. As I said, with the antipsychotics, tapering seems to be the a good approach to try. We haven't got that developed for the release study. That's not, tricyclics are not included in our study.
A question about the Maudsley De-prescribing guidelines. The question, is it available in New Zealand? I guess it's available. I got a Kindle.
Yeah,
I think
yep,
it is.
or buy from Amazon or wherever you get your books. Yeah, widely available. Yeah, go online.
What are the dangers if a patient didn't follow advice and shows a really rapid reduction?
Well, the dangers really are that they would experience withdrawal symptoms, and that's what we're trying to avoid, because there's some question about people committing suicide. Certainly the suicidal ideation, and that's the last thing you want. But they can be very unpleasant, these withdrawal symptoms. So if somebody follows, does a very fast reduction or stops suddenly and experiences withdrawal symptoms, they should just go back on the drug until the symptoms settle down and then they're feeling better. And then if they want to stop, they do it more slowly.
So what if someone has a history of recurrent depression but has been stable for a number of years? Can they stop?
I think that's going to be a difficult question to answer as a sort of a general thing. And as a GP, it's your role as the prescriber to try and balance the risks and the benefits. There certainly are risks when you attempt to stop these drugs. People can experience very unpleasant withdrawal symptoms. So it's not something to be taken lightly. On the other hand, there are real risks associated with staying on them. And given that everybody's different, if somebody wants to come off it, even if they've been on them long term, then I think it's your duty as a doctor to help them do that in the safest way we know how to do it. And then if they don't succeed, or they decide it's not worth the risk of stopping, then they don't stop.
You mentioned in your talk about having talk therapy alongside withdrawal. Presumably you'd recommend that if it's available.
Yep.
So this is from Glenn. How have you found using melatonin at night useful to help with the occasional insomnia from withdrawal?
I haven't tried it.
Okay.
For withdrawal, but yeah, people seem to like melatonin otherwise, generally speaking. So I guess the thing is with withdrawal symptoms, there are some sort of the one biggest strategy you can do to help your patients minimize withdrawal symptoms is slow hyperbolic tapering. But other strategies might be looking after yourself, eating well, sleeping well, doing a little bit of activity, staying connected and distracted, not drinking too much alcohol, not doing any other sort of drugs, because there's some suggestion that even drugs like antibiotics can interfere and make people more likely to experience withdrawal symptoms. So that sort of stemmed from the melatonin thought, and I don't know of any research saying that melatonin makes things any better or any worse for withdrawal symptoms.
Question here from Ramadan. Some patients can discontinue SSRIs without experiencing withdrawal symptoms. Is it worthwhile to attempt a shorter tapering period initially to gauge the response before proceeding with a slower tapering approach?
Yes, I think that's reasonable. If somebody hasn't been on the drugs for very long, they're not on one of the high risk drugs, and they feel fairly confident and also fairly desperate to get off these drugs, so they want to get pregnant, in 6 months' time or something. You could definitely try, the 10% taper, faster taper, and 1 to 2 weekly step downs, and see how they go.
If you decide to have withdrawal symptoms, so this is presumably somebody wanting the kamikaze approach, how long does it normally take before it's passed if people just went cold turkey? I mean, is that an option?
We've got an application in at the moment for funding to sort of look at that, to try and really map out the time course for withdrawal symptoms. And there's some suggestion that they sort of follow a bit of a wave pattern. So they build up gradually, they peak, and then they taper off. And that might be over a few weeks. So it's not going to be a year. If you cold turkey, and then you get withdrawal symptoms, it might be over several weeks. But again, it's likely going to be related to, the duration of therapy, how long somebody's been on the drug, what particular drug it is, what dose they're on, and factors like that.
And people, that's a long time to tolerate things like sleep problems and stuff, isn't it? I think that would be a hard way to go. Somebody comments here from Patrick, I'm totally on board with this topic. I think, how did we get it so wrong for so long in New Zealand? I think everyone got it so wrong for so long, didn't they, really?
Yeah, I mean, I think, there's a history in medicine of drugs becoming, fashionable, and then everybody's on them, and then, oh gosh, you wake up and you realize that there are problems here, and also, that perhaps everyone shouldn't be on them. So, and I think it's fair to say that awareness about withdrawal symptoms has really only become, much more widely known in the last, few years. So we can probably forgive ourselves for, falling for the pharmaceutical industry, promotion of these drugs to us, and genuinely believing that they were going to help people and not harm people when we started people on them.
And to an extent, we leave medical school a little bit in love with our drugs and devices, I think, and it takes quite a while to sort of get that into perspective, I think. If it's called an antidepressant, it's going to fix it. Antibiotics fix infection, antidepressants will fix depression, but not so. And I think it's taken me a long
I mean,
behavioral active most effective treatment for depression.
That's right. Yes. So, antidepressant perhaps might be a bit of a misnomer, and they might be better called numbing drugs, because they just, numb everything. But they've been cleverly marketed as something that's an antidepressant.
Which antidepressants are not able to be crushed or dissolved in water?
Unfortunately, venlafaxine, duloxetine, there's a few of them. And so you can only use the compounded capsules.
Okay, so got stuck on citalopram around 8 years ago. Now definitely keen to give a slow hyperbolic taper a go. Is there a table I can use for my GP's oversight? A quick Google didn't yield much. Obviously, sounds like a patient attending.
Yep. So I can send you that, or in the Maudsley De-prescribing guidelines, it's there as well.
Question here: do you check CYP 450 genetic variation? I don't know how you do that. Rapid versus slow metabolizers to tailor the speed of withdrawal in a person.
Yeah. So we're again, that's another grant application if they'll fund us. That we're looking at the moment to see whether there are any particular markers for people who are more likely to experience withdrawal symptoms or more severe symptoms. So no, we haven't got the answer for that at the moment, and no, we're not doing that currently. But it's an area of interest, maybe helpful.
Just coming back to that switching to fluoxetine, what was the reason you didn't think that was such a good idea? Because
if somebody's on venlafaxine and then you stop that suddenly and start fluoxetine, they will experience withdrawal symptoms from the venlafaxine or whatever it is, even though you've got them onto fluoxetine.
Okay.
So it's not recommended or very likely to be successful.
Look at it as to come down on the obviously quite a bit interested in the compounding pharmacy. It wasn't something I had thought of, although I think it's relatively expensive. Somebody put some prices here. Compounding chemists are Australian, not actually, no, there are New Zealand ones, at least one in Auckland on the North Shore. That's something.
Yeah, but that is a more expensive way of doing it.
Yep.
For sure. But so some people prefer that convenience and don't mind the expense. Others don't mind the fiddliness. And some people actually open up the capsules and get a pair of pharmacy scales and count the beads or weigh the contents of the capsules themselves and then put them back in a little capsule to swallow.
Here's this is sort of the opposite issue. The hyperbolic pattern, does it also inform us when to starting and titrating up doses? My understanding on the titration thing is actually high doses aren't any better than lower doses.
Well, that's the hyperbolic thing. You get very little difference
with the higher doses.
With the high doses in the transporter occupancy, yeah.
Do you also have tables for reduction of starting doses 15 of 100 milligrams of sertraline, or do you just approximate?
For the sertraline, if somebody's on 50, you just, you're already on step 2, so you just start there, or step 3, depending on or step 4, depending on which one you're on. So 50 is part of the schedule as you come down from 100 anyway. So you just miss those first few steps if you're already only on 50.
Because the real problem's at the end, isn't it? I think that's actually quite a good take-home message. Yeah. So we've had just gone past 8:45. Lots of really good feedback about this talk. I think it's a great one actually, and a really good, really large audience. So thank you very much for doing this for us tonight, and thank you very much just from the universe for doing this sort of research. I think it's fantastic that you've got into this.
Fantastic. Well, thanks very much, Bruce, and thanks very much, everyone. And do feel free to email me if you'd like, a request a tapering protocol.
Great, Katharine. Thank you very much.
All right. Lovely.